It's nice to get applause before I've even started. So, hi everyone. Welcome to everyone in the room and anyone who's joining us online. I'm Liam Galvin. I've been asked to chair this session on genetics, the future, what's happening at the moment, and what it will tell us in the future about pulmonary fibrosis. It's close to my heart because I come from a family who've lost 4 members to familial IPF. And like we've done sessions on genetics before, but I think this is a good opportunity to look at the basics, where we are, what we're hoping, and also to hear from a patient carer perspective around genetics and gene therapy. So without further ado, because I want to maximize time for questions and discussions at the end, the full bios of our speakers are available on the agenda and in the Swapcard app. But we have Killian Hurley from Dublin. He's a respiratory physician, researcher. He's interested in his understanding the genetic cause of pulmonary fibrosis. We have Chantal van der Zungen. She's a colleague from the Belgian French-speaking Patient Association. She sits on the board of directors of the federation and is vice president of her own association. Antoine Fadou is based here in Belgium. He's a respiratory physician as well, with a particular interest in interstitial lung diseases, familial fibrosis and connective tissue disease related ILD, and he's actually the ERS chair of Assembly 12.2, which deals with interstitial lung disease of known origin. So thanks very much to all my speakers for joining me, and we'll start off with Antoine. Thanks, Antoine.
Thank you, Liam, for the nice introduction. Thank you for having me this afternoon. Oops, this is not the proper, it's not my presentation, actually. Is it possible to switch to my presentation? Yeah. So in the next 10 to 15 minutes, I will try to provide you some key relevant information on familial fibrosis and the genetic underlying mutations. I will also give you some hints on what means having a mutation in familial fibrosis, and I will discuss management of those particular cases. If you want to read more in details about familial fibrosis, I invite you to consult and read the European Respiratory Society statement on familial pulmonary fibrosis when we discuss all those matters in details. And Liam, who is there, was a patient representative among our panel. So please feel free to read this important article, I think. So, all started around the early 2000, when some studies suggested that pulmonary fibrosis could be familial. And one of the first one is that study set in Finland, when they made a registry of all IPF in Finland, and then they found out that first, around 5% of patients had a familial history of fibrosis, and two, they were able to cluster some mutations around certain areas, proving, without any genetic test at that time, that indeed there were clustering of some families depending on the region of interest. In Belgium, we also made a registry study. It was a ProofNext registry, including almost 700 patients, and we found out that 12% of patients fulfilled the definition of familial fibrosis, which is having at least one first-degree or second-degree relative affected with any form of fibrosis. We also include in that definition people that develop pulmonary fibrosis below the age of 50, in the absence of autoimmune disease, of course. So first important information, yes, familial fibrosis exists, and it accounts for around 10 to 15% of our patients. When we look at genetic mutation underlying those diseases, this graph shows you that, and this is true for other mutations, that actually some very common mutations have a modest effect, and that's normal because from the point of view of evolution, very common mutation should not lead to the death of the people, otherwise we would not be here. But we are interested in more rare mutations that have a very high effect on the disease itself. There's an exception. It's the MEC5B variant, which has nothing to do with familial fibrosis. It's a risk factor, genetic risk factor for fibrosis, especially in Europe and United States. But it is found equally in familial and sporadic forms of pulmonary fibrosis. And when we look at familial pulmonary fibrosis, and we take interest of the genes that are involved, first thing, and it's quite disappointing for you patients, but also for us doctors, the majority of the underlying mutation is not found. Actually, I don't know whether you saw, but this is publication from 2023, and I think the reviewers were a bit asleep because they say unknown in 53%, but it's obviously less than the half, so probably it's 43 actually. But well, it's been published anyway. So you see that in almost a half of cases, we don't find any mutation. And then when we find something, most of the genes relate to what we call the telomere complex, telomerase complex, which is about senescence, and I will come back to that in a moment. Very small proportion of other genes, surfactant genes, that are very peculiar cases with ILD occurring at a very young age, sometimes combined with high incidence of lung cancer. So what are telomeres? Telomeres are non-coding DNA strands that are located at the end of our chromosomes, and actually they protect our DNA from degradation during the replication of cells. The issue, well, the characteristic of the telomeres is that they're shortened at every cell division. And when you don't have any telomere left, the cell goes into senescence, which is a form of cell death. In some tissue, you have a complex that is called a telomerase, which is a super enzyme, a protein that is able to build other proteins or genes, that somehow compensates this phenomenon. So in some of our organs, we have an active telomerase that is able to regenerate telomeres, otherwise our organ would go into senescence too early. The issue is that we are not all equal. It's like the size, it's like your, the weight, the age. Some people have longer telomeres than others, and some people, unfortunately, have much shorter telomeres than others. And in some cases, having short telomeres is caused by having a mutation in the gene that codes for one of the proteins of this complex telomerase enzyme. And that's what we are looking for when we have patients with familial fibrosis. We are looking for some mutations. We have gene panels to test the main genes involved in this complex. And what's the issue if you have a telomere-related gene mutation? You have two things. First, of course, it may cause organ defects because, as I told you, if you don't have any telomere, if you have a non-functioning telomerase, you will not be able to regenerate your telomeres. And so in some very high turnover tissues, like bone marrow, it will lead to stem cell attrition, which in disease will cause aplastic anemia, so having no more blood cells or white blood cells. In low turnover tissues, like the lungs or the liver, it will also cause a defect in local progenitors, which promotes the occurrence of pulmonary fibrosis, and that's why we are here today, but also liver fibrosis, which is much less studied at this point. There are also some association with other defects like autoimmunity or skin disease. So this shows you, and all patients do not develop the same disease, so this is an important point on telomere-related disorders. It's variable. In the same family, you could have one patient with pulmonary fibrosis, another one with liver fibrosis, maybe one with both, and maybe one member with the mutation that does not develop any disease. Another issue, as I told you, is that you will end up having shorter telomeres because you have a defect in your telomerase complex. And this is transmitted to the offspring, meaning that you will have a phenomenon called genetic anticipation. The next generation is likely to develop the disease a bit earlier than the previous one because you receive short telomeres from your father or mother, which will lead to a disease earlier in life. So two important information, variable penetrance and genetic anticipation. So this is the way I explain that to my patients when I find out that they have a mutation. It's not, those mutations, they do not cause the disease itself, they amplify the risk. So if we have this very simple graph and I put it a threshold to develop fibrosis. In sporadic pulmonary fibrosis, you know that you accumulate some bricks. So you have aging, you know that fibrosis mostly affects older people. This is one brick. Of course, if you've been smoking or if you work in a factory with lots of fumes, you increase your risk. And sometimes there's also another trigger like autoimmunity or a very common variant like MUC5B. And so you reach a threshold and you develop the disease. What occurs in familial fibrosis when we detect a mutation is that those patients, they start in advance. They start with this large brick of a rare pathological variant. And so they need less triggers, additional triggers to develop the disease. So aging will be one, for instance, and then a small part of environmental, sometimes nothing, is sufficient to reach this threshold on the graph. Other important information, as I told you, is that familial fibrosis is heterogeneous. This is an example of one of my patients. She's a woman. She has rheumatoid arthritis-related ILD with fibrosis. And actually, I found out that her brother died from IPF. He was a heavy smoker. And when we made a familial inquiry, we showed that her father also died from lung fibrosis at the age of 84. She also developed fibrosis with RA. She's a non-smoker. We managed to measure her telomeres, and we express that as a percentile of expected value based on the age. And she has telomere length below the first percentile, so very short telomeres. And we found out a mutation in one of the genes that is implicated in the telomerase complex, TERT gene. And this is a pathogenic mutation. So class 5 means that this is a pathogenic mutation. It's a genetic term. They class mutations from 1 to 5, 1 being completely benign, 5 being the most dangerous. Another example, can you launch the films, please? So there are, so this is a family, 3 brothers, and they developed 3 fibroses with different patterns, very different patterns. Actually, all of them, if you see, they have short telomeres, 5th percentile, 1st, and 5 to 10th percentile. We found in 2 brothers a pathogenic variant of the gene TERK. And the 3rd brother, also developed fibrosis, is a smoker, is a non-carrier of this variant. So he doesn't have the mutation, but he has short telomeres because he received short telomeres from his parents. And so that's what we call a phenocopy, meaning that this member of family, he doesn't have the mutation, but he behaves like he had it because he has short telomeres. And so those are our local data on almost 200 tests that were performed at my hospital. You see that in most cases, we did not find any telomere-related gene mutation. And then in a bit more than 25%, we found mutations. What is really difficult, both for patients and for us physicians, is that this is a new field and evolving very fastly. And actually, lots of the mutations we identify are class 3 telomere mutation, meaning that they are of unknown significance. We don't know yet whether those mutations are dangerous because maybe they were not yet identified in several families. You need to confirm with other cases. You need to use complex tools from the geneticist to be sure that those are pathogenic mutations. And to be honest, we don't really know what to do with those class 3 mutations. So that's why it's very important to share the data, to gather as much information as possible, because we are really moving in a field of uncertainty, and this is very stressful also for the patient. I guess we will discuss that in a couple of minutes. Another example of a very large family here, when we managed to identify a third mutation, and actually when you see when some of those patients, they had a very long history of searching for medical advice, looking for diagnosis, and they did not understand why all those families were affected, also those family members were affected with a similar disease. And actually, when they were the first one was addressed, we found out that there was a mutation. So, what are our current care pathway for telomere biology disorder patients? This is how we work in my hospital, but I think it's similar in other centers. So there are two different ways to, two different positions to consider. First, of course, you have the index case, so the patient himself. Either he has pulmonary fibrosis and we suspect a TBD, or liver disease, or both, or hematological disease and we suspect telomere biology disorder. In all those cases, or if they combine, we propose a full organ-specific workup with telomere length measurement with a technique that is called FlowFish, which is available in our hospital, and also a sequencing of the gene of their genes that are potentially implicated. Then, if we confirm, it will lead to a specific management. We also propose a multi-organ workup with some health and diet advices, hemogram, liver enzymes, even if we don't have any signs of liver disease at first. Pulmonary function test, high-resolution CT, obviously, and FibroScan is to study the liver fibrosis. Then we have the issue of the relatives. How do we deal with relatives of those patients? We know those mutations, they are transmitted, and they are dominant, meaning that you have 50% chances to transmit the mutation to the children. Then we propose a genetic council, and almost never before the age of 18. So I think it's important to stress the fact that even in familial fibrosis, you will not develop fibrosis before the age of 30 or 40, so you don't need to stress people too early. So my take-home messages are that familial fibrosis accounts for 10 to 15% of cases. This is the definition of the ERS. Unfortunately, we still fail to identify the mutation in half of cases. Most mutations refer to telomere-related genes, and I think that experienced ILD centers should propose tailored management of those patients. With that, I thank you for your attention. I will hand them to Kilian for the next talk.
Hello, everyone. Everyone still awake? You all got some coffee and some chocolate? Excellent. Very good. I'm glad to be in Belgium for all those things. Okay, so over the next 10 minutes or so, I'm just going to retry and outline what are the current treatments, what are the treatments in the pipeline, and what are the very future treatments for fibrosis. And in particular, I'm going to reference some things about familial fibrosis, but generally speaking, this is about fibrosis in general, but some other little pieces about the genetic forms of fibrosis too. Okay, so what are the approved treatments? And I think lots of us in the audience know about these. So there's two approved treatments, nintedanib and pirfenidone, and treatment which is approved in the US, near to approval in Europe with nerandomilast. Interestingly about nerandomilast, there's a study ongoing in familial fibrosis in the UK as well to see how it might be useful in those patients in particular. So those are the drug treatments at the moment, at least. Pulmonary rehabilitation is really important, and that's something that all patients should be able to access and can improve outcomes. Oxygen therapy can improve quality of life. Diet and exercise and vaccines are extremely important for patients, particularly those that are losing weight or have overweight. And in the end, lung transplant as well is an option for appropriate patients as well. I think there are some caveats, and I think Antoine and I might talk about that as well, about transplant in the familial pulmonary fibrosis patient as well, because there may be some augmentation or changing of immunosuppression for those patients as well in particular. And Antoine as well will talk about, I think there's some new guidelines about testing for familial forms of fibrosis before transplant now, which has become a standard of practice, or at least recommended. Just to mention as well that in the familial fibrosis, we're managing the lungs, but we may need to manage other organs because those may be affected, such as the liver and such as the blood as well. So for blood diseases such as anemia, some blood cancers, and liver disease as well, which patients may be at risk of. So these are extra things that clinicians and patients need to consider and appropriately manage as well in that setting. Well, if we want to have new treatments, how do we find them? So let's start at the beginning. So where do we find new treatments? So we start usually in cells. And to give you an idea, there's lots of different studies in cells for fibrosis. So maybe only 1 in 10,000 of those studies end up ever being a clinical drug. So a really small percentage. So lots of work, but it's like a funnel in terms of the number of studies that are needed. There's also what we call preclinical studies, where we study these drugs in mice. And to give you an idea of that, from the preclinical studies, drugs or compounds that go as far as a preclinical study in an animal, only about 1 in 10 or maybe even less end up ever going to a person. That's a really good point, because we don't want to cure mice of fibrosis, we want to cure people of fibrosis. So that's an important factor, right? So, and when we do the first in human studies, that we call that a phase 1 study. And that's when we are giving a treatment to patients as well, and we call that a phase 1. And so clinical trials in pulmonary fibrosis are hugely important. And let me just go through the phases. I've just said about phase 1, those are usually smaller studies, and if you can see the very small writing here, usually 10, maybe the maximum about 100 patients. Phase 2 is then when we study safety and the dosing, and those are a little bit bigger, maybe 100 to 300 patients. Phase 3 is more focused on, is this safe for the patient, and does it actually work for that patient as well, or on the average for patients. Those are bigger, anything between 300 and 3,000 patients, but typically in an IPF or pulmonary fibrosis study, it'll be about 1,000 patients. And phase 4, we don't tend to talk about this much, but after the drug is released and on the market, we do there's phase 4 studies, which I look at, is there any other complications or side effects that might be important for those patients? So what are the benefits of doing a clinical study for patients, but also for others? So we know that those patients that are involved in studies, they're more actively involved in their own healthcare, they have more engagement, they have access to new treatments that they may not be publicly available or on the market, and they continue to receive high quality of care. And actually, when you look at patients that are in studies, they do better, in fact, clinically than those patients that are not in studies, even if they're in what we call a placebo, or not actually getting the drug, because they have maybe an increased amount of monitoring. Doctors and nurses are seeing them more frequently as well. They obviously have this opportunity to have a treatment that may be more effective than what's on the market at the moment. And importantly, the results of that study, whether positive or negative, may influence and help other patients or other family members in the future. So there's quite a lot of benefits. I think some things to maybe think about when you're looking at clinical studies and whether you might think about adopting or getting into a study is just beware of studies where you're asked to pay to enter a study. That really doesn't happen in a clinical study. You wouldn't have to pay, but also you would not be paid to be in a study, generally speaking. Also, beware if it sounds too good. So if a treatment is promising something that, a cure within a few weeks, obviously that's something that, may be too good to be true, and just be cautious about those kind of things. I think some places where you can find some really good information about clinical studies on the PFF website, the pulmonarfibrosis.org, there's a very good clinical trials education center, which gives you lots of information about what is a good clinical study, what are the benefits, what are the downsides, and where to find studies. And if you're wondering about a study, someone sends you a link or someone is marketing towards you about a clinical study, you can check on clinicaltrials.gov if this is a registered study in the US or worldwide as well. So you can have some reassurance that study is at least registered and is run in some kind of orderly way. So that's for the studies that are right now. And I believe there's a lot of medications in the pipeline for both fibrosis and also for familial pulmonary fibrosis. But what are the treatments of the future? And so I was just going to categorize these in two different ways. And I'm going to talk about cell therapies first, because those are not treatments that are in the market at the moment, but they may be in the future. Some of you may know about CAR T cells and new treatments for cancers, and these are cell therapies. And I think those are on the horizon for fibrosis, but not yet. So let me talk you through some of them right now. So you may hear people talk about stem cells. So what are stem cells? So these are cells that have the ability to form any cell in the body. So they can become, for example, a cardiac cell. So this is some stem cells beating actually in the dish that are made from stem cells called induced pluripotent stem cells, or we call them iPSCs. So these are cardiac cells made from a patient, but they're made from their stem cells. Interestingly, we can now also make lung cells from stem cells. And we use these in different ways, like a preclinical study to test different drugs on that, but we can also now start to think about how we would use them in personalized treatments. So designing treatments that are specific for a mutation or specific for a person. So that's on the horizon. So what do stem cells, what could they do? They can replace a cell that's damaged, so that you can imagine replacing a lung cell that's damaged. They can give a patient something like an immune cell that's made from a stem cell that can do one of two things. It can reduce the signals that make fibrosis, or it can remove the fibrotic cells themselves. I can just briefly tell you that we've just received funding for a study that is looking to generate new type of treatment for fibrosis. It's funded through an Horizon study led by Hanover with 10 partners across Europe, called the BRETT study. And this study sets out to generate an immune cell called a macrophage from stem cells that can be used to go into a patient's lung and search for fibrotic cells and either signal to them to reduce the fibrosis or to remove them. But there are some challenges, like with everything that's on the horizon, some challenges for us to look out for. These cells could upset the immune system. Many cell therapies in the past haven't worked, such as we call MSCs or mesenchymal stromal cells that have not been shown benefit in fibrosis. And they could be expensive or impractical as well. So these are treatments of the future, but yet there's a lot of work to be done for us to get there. Another future treatment is gene therapy. And so Antoine really nicely showed us how the genes can lead to, or at least be associated with, fibrosis, right? So, and in this example here, would like with gene therapy to either replace a gene, so that's change the code that's in there, or deliver what we call an mRNA, which is a signal beyond the gene that can make a protein or make a structure such as telomerase, which Anton was talking about as well. So that's the two things that you could do. Or the other thing that the gene could do is it could generate a new signaling protein which could stop the fibrosis or reduce it as well. And so at the moment we're working on a project where we're making mRNA for something that makes telomerase, so that thing that protects your telomeres. And this is a European Research Council grant that we're working on. And that's hoping to design specific treatments for patients who have telomere-related gene mutations. So in a way, tailoring the treatment to that mutation that that patient has. And in a sense, replace that gene that's not working or replace that protein. Again, there's challenges with this kind of work as well. So would we deliver it directly to the blood, or would we be able to deliver it directly to the lung? And with anything, when you're giving it to a patient, there's always this risk of causing some upset to the immune system. So we talked a little bit about those two kind of categories of possible future therapies. But really important in generating new research is research networks. So when we work on these rare diseases, we need to work together in research collaborations. And one such one that we were involved in was this Cost Innovator Grant. And we ran a training school in Dublin where we invited people from all over Europe to learn how to work with stem cells and learn how to work with stem cells specifically that are designed towards pulmonary fibrosis, and we were able to publish on that. And we also developed this framework to develop new treatments. So in the next minute, and then I'll just conclude. So really the highlights of that are, the important things for new treatments are international cohorts, biobanks, and some examples here. So they're really important that we have samples from patients that are really generous and have given us their blood or other tissue samples so that we can work with. Preclinical models, so I mentioned some cell type ones and animal models, so we're developing new types of models that we can use to test new drugs to see if they would work. Clinical trials, just outline those in terms of the different phases 1 through 4 that are really important. But the most important part is patients. So we need patients' engagement at advisory groups, at biobanks, and help us with publications and clinical trials. So really important that we have that engagement and contributions from patients. So finally, just to say, there are benefits from clinical trials for you and for others. There's sources of good information on clinical trials. I would encourage you to have a look at these websites if you're interested in being involved in a clinical trial. Beware of trials that ask for your money or have very little evidence for them as well. And please get involved in biobanks and advisory groups. You're obviously already a very interested group because you're here. And very finally, keep positive. I think there's new treatments on the way. So thank you, and delighted to take your questions after chat time. Thank you.
Changing size. Well, hello again. I'm going to tell you a little bit about our experience with gene therapies and with gene mutation. So my husband, Albert, underwent a genetic test in 2019. That was 5 years after having been diagnosed with IPF. These tests were analyzed, I'm going to read that, by the Biogem Department of Genetics in Paris. The results we received in 2023. That means 4 years after the test had been undertaken. undertaken. And they had to be confirmed by a second test, which was faster. And diagnosis was short telomere syndrome related to mutations in the third gene. That was new to us. The report, the 2019 report, strongly recommended regular checkup of organs generally affected by third mutations, psychological support and genetic advice to the family members. So the information that we received then led to a consultation with the pulmonologist, and we learned on the way that Albert's idiopathic pulmonary fibrosis was apparently triggered by a genetic mutation. And we were also told that shorter telomeres caused a more quicker development of the disease and a shorter decline for those patients with idiopathic pulmonary fibrosis. The point was that at the time Albert had been transplanted, so we said, yay, we've gone over that part, no problem. But still, there were problems because at the same time or just after that, we learned that other organs can be affected by this mutation, as Antoine explained earlier on, so that liver and blood are also at risk. So not yay, finally, anymore. We had to move over to different testing, for instance, bone marrow. And now Albert is being regularly checked up for these organs, so both liver and blood. So which is in itself a comfort, I must say. But still, that was a shock. We had the first genetic counseling in 2024 with psychologists and specialists. That was a total disaster. I mean, a disappointment at least. So we had hoped that this counseling would alleviate the burden that Albert was carrying. What kind of burden? First, the feeling of culpability because of his offspring and his family members, and also a feeling of shame, which is absolutely ridiculous, but which you cannot avoid. And that was particularly painful. So we thought that's going to help. They were going to receive, advice on how to deal with that. We didn't have any support on that field. We also had expected advice on how to share this with the family. Albert has six siblings, 3 children, a number of grandchildren, aunts, uncles, cousins. So we expected to have information on how to communicate with these family members. And the only answer we got was just take it, do it the way you feel like doing. So no advice. And when the family members heard about that, well, that triggered anxiety. Maybe also they might have been angry hearing about that. And the idea, of course, the problem for them, and that's understandable, is should I be tested or not? Am I wearing this? Am I carrying this or not? So it's understandable that I should be upset. But we were the recipient of this, and that was not fair. So I'm sure we would have really appreciated a bit more empathy and support. Now, I hesitated a little bit before choosing to tell you the end of my story, but I believe it's also part of the journey. So Albert has 2 children, as I told you, so they all underwent genetic testing in 2024. His younger son found out that he was carrying the 3rd genetic mutation. A few months later, He was diagnosed with acute myeloblastic leukemia, and he passed away last April. My stepson, my dear stepson, was 45 years of age. Well, I want to conclude with a wish list. And this wish list is for early genetic testing. Expert and timely medical advice, appropriate counseling and support like coping with the diagnosis, coping with the fear or guilt, conveying potential health risks to your family, coping with sharing the information. And mainly, I wish for the quick development of cell and gene therapies to treat familial pulmonary fibrosis. Thank you.
Thanks very much, Chantal, for telling of your experience, and to both our speakers for sort of giving us an insight into their profession and the work that they're doing. And I suppose Chantal's story ties in with Antoine's talk about how it is a developing field. There's still much to be learned, and obviously certain institutions and certain individuals have to maybe receive better training, or there has to be guidelines put in place for how genetic testing, counselling, and work done by patient organisations to prepare people for the choice of whether to get genetic tests or not. But maybe Antoine and Killian, your comments on generally like the challenges faced by patients, whether to take tests or I know you emphasize the importance that the more tests that are done, that adds to research and knowledge. But obviously there is a Pandora box element to it as well for families.
Yeah, thank you. I don't know whether you can hear me. Yeah. Okay. Yes, indeed, this is a moving field, and that's why it's very important to be cautious with the message we deliver to patients. And I think this really requires collaboration with all specialists. So what we and others try to propose to patients affected by familial fibrosis, or where we suspect a telomere biology disorder, is really to take the time to explain and to propose a full workup. And of course, with regards to what you just told us, indeed, genetic counseling is a challenge. It's still a challenge, and because we are facing lots of unknown significance variants where you don't know whether you should test or not among family. And as you told us, testing is providing an information that can be itself dangerous, and people, they process and manage and they process this information in very different ways. And so we are always asking ourselves, especially with geneticists and psychologists, okay, what am I giving to this family when I deliver a message that there's a pathogenic mutation? So this is really a challenge, and we are still learning, and also we are learning a lot from patients themselves. So I hope that the future will be brighter for the patients.
Thank you, Antoine. Thank you, Chantal, for sharing that moving account of a personal account. I think you've really, excellently displayed and told us about the kind of anguish and the difficulty in getting a genetic diagnosis, and also the challenge of not being able to get a timely diagnosis. It's really important. And then the tools to be able to explain that to family members. It is a challenge, as Antoine says, in our clinical practice. I don't think there's a one-size-fits-all approach to sharing that information and also sharing it with families. I think patients need to be offered advice, maybe a number of options of advice about how that might be shared. I think some tools that are emerging are, written advice. So like a letter or something that can be shared with their general practitioner or someone that knows the patient and knows the family. Because of course, patients come and see us, but they may only see us every 3 or 6 months. And there may be other people that know that patient much more closely, like their general practitioner or someone that's close to them that can help to share that information a bit better as well. I think one of the big challenges we have is that the field is just emerging so quickly. So really, if we had this conference 10 years ago, we couldn't talk about it without any level of information, only to know that there's familial, but not knowing what genes. And the second part of that as well is that it's complicated in that it's not, and Anton really explained that well, it's not just that you have the gene and therefore you have the disease. You may have the gene, but may have a very mild form of disease, and we don't know when that would happen. So that uncertainty adds, I think, to the anxiety that patients have, so it is difficult.
One thing I forgot to say is that we also discovered that one of his aunt died of IPF, another one of liver, probably fibrosis. But what you've just said about, information to the family, I think it should not, the burden of it should not be on the patient themselves, but with probably the general practitioners or somebody else doing the communication rather than Albert telling his sisters, and I mean that's very harsh, and there should be help there, which there wasn't.
Yeah, I mean, I suppose in the field of genetics and the way counselling is going, it is important for us as patient organisations to sort of like look at that subject and do a call for action. Say, it's in the same way we're calling for more ILD specialist nurses, we should be looking at if genetic testing is being done, that there are appropriate supports in place and that they do think outside the box and maybe go, as Killian says, through the GP route or through a sort of liaison officer who's maybe more experienced in dealing with such matters. I think we've got some time for questions if anyone's got any questions. There's a few.
So we have one online question. What are the basic and exact tests that children and relatives of patients should undergo to determine whether they're at risk of developing the disease?
Okay, so I think there are currently 2 tests that are available. It's possible in some centers to measure telomere lengths. And it also, as clinicians, it gives us a clue about the propensity of the disease to progress faster, because having short telomeres really will increase the risk of progression, regardless of the presence of a gene. And then the second set that you should propose in a familial fibrosis is to test for the genes themselves. So those are basically the 2 things that are feasible.
Yeah, I mean, just to add to that as well, I think, screening, even when we don't find a gene, I think actually patients, families having a CT scan, generally we advise that after the age of 40 or so, because we find that the fibrosis does not develop until that time. So even in a family that there's someone that has fibrosis, but we haven't identified a gene, we do recommend that other family members also have a CT scan as well.
So this is also, indeed, in the absence of mutation, it's a bit similar as other diseases like breast cancer, for instance. Regardless of a mutation, having several members of a family with familial fibrosis is a risk factor itself. You almost don't need the gene to state that there's a risk factor.
Question from Harry there. Is it Harry? Yeah.
Thank you. And first and foremost, also on my side, thank you very much for a very informative presentations. And if I may say so, an impressive presentation by Chantal van den Dungen. I do have a question. Am I right in my understanding that shorter telomeres are not necessarily going to be there in a next generation. Is this the message you try to pass as well?
So if a patient with short telomeres and mutation has children, there's a risk that they will have short telomeres, even if they don't have the mutation. But it is also a very complex field from the genetic point of view, because we do see families where there's some ways that the nature finds to compensate, and then sometimes you do have children of TBD patients, they don't have the mutation, and they have longer telomeres because they have some mechanisms that have compensated for that, yes. But in some cases, you do also have short telomeres without the mutation. That's the example I showed you. That's what we call phenocopies. Yeah.
Helen?
I wanted to ask, within your services, and Chantal, from your experience as going through this as a patient with your husband, whether you actually met a clinical geneticist. So how we work our service in Cambridge is that if we identify a patient who has a genetic variant, we then work with our clinical geneticists for helping to establish the family screening and how that should be done. So, and they're able to provide the counselling and support that I'm not trained to do. And we do have a letter that the family members are given to us to give to their relatives, but as part of that, you know, it's obviously an independent individual's choice as to whether they want to have a genetic test, and so, you know, that bit is that the information is given to the relatives so that they can read that, and then if they want to discuss, we suggest that they go to their GP to have that discussion. I think it's certainly within the UK, it's quite hard for a GP to have that level of discussion without the information, because these are rare disorders and they may not have anybody else in the practice. So I think it's how you connect up the services so that there is a level of communication to help people go through this very difficult journey.
Well, thank you. To be honest, when we decided to go to this genetic counseling, what we expected was that type of letter, you know, to be sent to the family members,
Yeah.
and that didn't happen. I mean, we were just told it was a kind of do-it-yourself thing, you know, if you wish, and that was very unsettling.
One of the challenges is, I think, that a lot of these services have really, in terms of genetic screening, have really started as a research study,
Yeah.
and they may not have the support in terms of the clinical geneticists, the genetics counsellors to support them. And so what's happened is that centres trying to do the right thing in providing a service, they're not adequately resourced in terms of counsellors, experience, and also clinical geneticists at the consultant level as well. So really difficult challenge. And because lots of different countries don't have a standardized approach to genetics, genetic screening, it can be done in ways that maybe don't meet best practice. And so that has really been a challenge. And that, I think, speaks to the reason that we need better policy. We need more funding for these type of things. You know, when you think about it, it's 10 to 20% of patients with fibrosis have a family connection. So it's a significant number, but there isn't that significant resource applied to it across Europe at the moment.
I think there's another question there, a few rows behind Helen. Was there a question there? Yeah, Anne-Marie, sorry. Yeah.
Okay, thank you. A couple of points. First, I'd like to thank Chantal for her bravery in sharing that story, incredibly impactful. And I think it highlights the discussion to date on the importance of genetic counselling. I would say that Cambridge is very much a gold standard from which we can learn. And I think it's, as Cillian said, the field is moving very rapidly. And it is concerning with that rapidity that perhaps there are some clinicians who feel they can take on a role in genetic counselling, but it's very, very specialised, and done badly is impactful for the rest of not only the patient's life, but the life of the family. So I think you were mentioning a call to action, Liam. That's certainly, I think, something that we need to look at in terms of standards for genetic counselling. And I just wanted to ask Cillian quickly, you mentioned that in respect of suspected familial PF, around the age of 40 perhaps, we might be looking at a high-resolution CT scan. Should an ILA be identified? Where are we at the minute in terms of following up and monitoring?
Yeah, yeah. It's a really tricky subject. So interstitial lung abnormality. So that's what we see on a scan is really early fibrotic change. We think so. Those patients who have an interstitial lung abnormality and have a family history, so the risk of them developing fibrosis is much increased over those that don't have a family history. So a part of the challenge for us in the future is actually, as clinicians and as patients, is actually when we see an ILA, an interstitial lung abnormality, we really need to prioritize those that are at risk as well. So they need more monitoring, they need more closer monitoring, they probably need a CT scan every year or every 2 years over the next 5 years, because that might be the first part of us seeing a new fibrosis. And actually, to open the Pandora's box of lung cancer screening, we are seeing a lot more of these early fibrosis. But knowing that someone has a family history is really important, or male family history, and also if they have some kind of connective tissue disease, are all risk factors for that ILA going on to fibrosis. So it's an area that needs more research, I think, as well, because we don't know as much as we would like to.
First, I have a question, and after second point, I have an information. The first point, do you think have this genetic problem, it's an opposition for the transplantation?
Okay, so the answer is no. It will be quite the contrary, actually. So among my patients with familial fibrosis that could be eligible to lung transplantation, having found a mutation is an argument to go faster to the workup and to put them on a waiting list, because we know that they will progress faster than sporadic IPF. With regard to management, there are some modifications. I will not enter into details, but our colleagues that are specialized in transplantation, they now adapt some of the immunosuppressive regimens to lower the risk of side effects, which is greater in those patients. So no, it's not an obstacle at all.
Thank you, but I never received this information. It's not the fault of my father. It's not my fault. But it's not easy to diffuse the information because now name family.
No. Yeah.
It's something. Excuse me. It's something like a shame.
Yeah, I understand, like, and obviously this is a reflection that a lot more needs to be done around this subject. But I think we can draw this conversation to a close, but I'd like to thank Albert, Chantal, Antoine, and Cillian for this discussion. Thanks very much, everyone.